All right. Good morning, everyone. It's a pleasure to start the webinar this morning on the WHO guidance on TB surveillance, the guidance and the associated products on TB surveillance. Can I make sure that people can hear me and that we have the slides on? So I'm not going to be able to see the slides there?
Yes.
It's okay? You can see the slides? All right.
No, this is not.
They can hear us.
They can hear us. Okay.
The slides are coming
Yes.
up.
Okay. Are we ready, Gita? Okay. Great. So let's start with the webinar. Next slide, please. Just to once again say welcome to everyone. We appreciate your interest in this webinar. My name is Babis Ismanidis. I'm with the WHO, the global program on TB and lung health, and I'm the team lead responsible for strengthening surveillance, epidemiological studies, and data use for action team. To my left is Marek Lally, technical officer with the team, and next to him, Gita Parwati, also technical officer with the team. And to my right, I have Namdi Nwaneri, a specialist with TB and MNE surveillance focal point at the Global Fund. Next slide, please. So what we will be doing over the next 90 minutes is introducing the new WHO guidance on TB surveillance and its associated products. And we will be discussing good practices in TB surveillance. The guidance was published, in fact, it's now almost 12 months to the day. And it is already available in 4 other UN official languages, so Chinese, French, Russian, and Spanish. The Arabic translation is coming up very shortly, so watch out for that sometime next month. And we are also working on the Portuguese translation, and that includes the full guidance as well as the associated 6 web annexes. So what we will be, hopefully by the end of the webinar, you will have gained an overview of the core concepts, the updates, and practical resources that are available for support. We will also feature country case studies, where we will show you how countries have worked to improve the TB surveillance systems through digitization and through closing the gaps in underdiagnosis and underreported. We will then have a commentary from Namdi from the Global Fund, and we will open the floor for questions. Please keep your questions coming throughout the webinar. Marek and Gita will try to answer as many of those as possible throughout the webinar. Please use the Q&A button on Zoom to submit your questions. But then we will also have a dedicated part to this webinar where we will be addressing some of these questions. And then finally, we will close the webinar with a summary of what we will have presented, as well as a presentation of the next steps. Please do stick around until the end, because as part of the next steps, we will be running a poll on with some suggested future webinar sessions associated with this work. Next slide, please. And next again. So I will start from discussing a little bit the rationale, providing the content outline and the purpose of the surveillance guidance. Next slide, please. The TB community, the global TB community, has very early on acknowledged the importance of standardization of data recording and reporting. So previous editions to this surveillance guidance started being published really since the mid-90s. Early on with the DOT strategy, then there was an update in 2006, followed by the 2013-2014 update. And all of these previous editions had standardized case definitions and standard recording and reporting material. Since the last guidance in 2014, a lot of things have changed. So that guidance became outdated because we have new clinical guidelines for TB diagnosis, treatment, and prevention, because we have updated recommendations for the surveillance of drug-resistant TB, because there has been a huge expansion of the use of digital case-based surveillance in countries around the world. There's been a growing demand for more timely reporting of data. And very importantly, because of all the lessons that we have learned from implementing more than 100 national TB epidemiological reviews and surveillance assessments since 2013. We also saw this as an opportunity to consolidate all WHO guidance and associated products to strengthen TB surveillance. And of course, the overall goal of this work is to ensure continued worldwide standardization of TB surveillance in the context of WHO's TB strategy and the latest WHO guidelines on TB diagnosis, treatment, and prevention, while also promoting the use of digital case-based surveillance. Next slide, please. As a quick outline of the content, there are 7 main chapters. You see them here presented color-coded. The chapters that are presented in black font are ones that existed in the previous surveillance as well, which of course have been updated. So this is the introduction, the chapter on purpose, principles, and scope, a chapter on definitions, and a chapter on core indicators to report. But because this new guidance, this latest guidance, has a hugely expanded scope, we have new material. So we have new material on the use of core indicators for TB surveillance, on core data items to collect, on digital TB surveillance, and on data quality. There are overview slide sets available at the moment for chapters 4 and 5, but we will in fact update these slide sets to include all chapters in the document. Next slide, please. We also have 6 web annexes. There are 4 new ones on the common Web Annex A on commonly observed problems and suggested solutions for surveillance, as they have been observed rather, as part of the TB surveillance epidemiological reviews and surveillance assessments. There is a new edition, so that's Web Annex B, a new edition of the WHO TB surveillance checklist. There is a new annex on record linkage exercises to address underreporting. There is a new annex, Annex F, on the summary that provides a summary of the evaluation of case-based DHIS2 implementation in 5 countries. And there are 2 updated annexes on reporting templates for quarterly and annual data. And then finally, Annex E on the examples of reporting scenarios for diagnosis, start of treatment, and treatment outcomes. Next slide, please. Just to make sure that we're on the same page, and in fact, because it is important in the era that we're at, and when we are engaging with other disease programs, when we are engaging with the overall public health architecture, it is really important to define clearly what the purpose of surveillance is for TB and what the objectives for TB surveillance are. So when we talk about TB surveillance, we talk about the systematic and continuous collection, analysis, reporting, and use of data relating to TB infection and TB disease in the population. And we use the data collected as part of TB surveillance to address 4 objectives specifically. Number 1, to reliably monitor TB epidemics. Number 2, to assess the progress that is being made at the national, regional, and global targets. Number 3, to assess the performance of TB services. And finally, number 4, to inform planning, budgeting, policy, programmatic, and clinical action. Next slide, please. Now let's move on to the part of the webinar where we're really going to be covering the new material, the new content that is being presented. So we have 3 major themes. One around the new conceptual framework for the categorization of indicators, one around the good practices for strengthening TB surveillance, and another one around digital surveillance and associated products. Next slide, please. Before I go into these 3 main themes, I will say on this slide, I'm showing you a summary, a very brief summary of some other new features which are not the focus of this webinar. So, for example, there are a few updates to terms and definitions related to TB surveillance. I know there's a lot of interest on those. We're not covering this in this webinar, but we can definitely do that in future webinars. One of the new features also is that there is now a very clear distinction being made between diagnosis and enrollment on treatments, and we're doing that because we want to be able to clearly report separately people who have been diagnosed but not necessarily started treatment in order to monitor initial deaths and losses to follow up. And then finally, we specify core data items that need to be collected in order to calculate core indicators. And we do that exactly because we are promoting the transition of surveillance systems into a digital system. So rather than just presenting the standard reporting templates that are mostly for paper-based systems, we now also translate that into which are the core data items that need to be collected digitally by surveillance systems in order to be able to calculate the core indicators. Next slide, please. The first main theme is this new conceptual framework for categorization of indicators. Next, please. So I will start by providing you with an illustration of the most common types of TB surveillance systems and how the flow of data goes from the health facility to the national level. So moving from left to right, I'm presenting the 3 more common types of TB surveillance. On the left, we have surveillance that is mostly paper, based on paper, so the patient cards and the TB registers, when then there needs to be an aggregation that is done manually at the health facility level, sent up to the national database. Then when we move to B, which is the digital aggregate system, so these are countries where the quarterly level data, or if you like, the consolidation of the data happens digitally, and then digitally the data being sent from the health facility level to the district and the regional, and then finally the national level. And then finally, we have the digital case-based system where the information from the paper patient cards is entered into a digital TB register, and then the consolidation and reporting of data takes place digitally. Next, please. And then, of course, now we have the new we have a lot of countries that are moving towards the digital medical records, where there is no paper forms used anymore. So even the information on the patient is not captured on paper cards, but is entered automatically in a digital system. So quite a wide range of options for the surveillance systems for TB. Next, please. What we are trying to do and what we have been doing over the last 10 years is support countries to really transition from the left to the right, so transition to fully digital case-based systems that are interoperable or integrated with the overall public health architecture. And I will speak about that a little bit later as well. Next, please. But then also recognizing that the paper systems are harder, require a lot more work, and they're more resource intensive and more error prone as the data are captured, consolidated, and reporting upward. So imagine if you have to, for example, fill in a form with a large number of disaggregations and you have to do that manually. That is a lot of work for the frontline workers, and quite often there needs to be the quality of the data suffers from that. Next slide, please. So with keeping that in mind, keeping in mind the different types of surveillance systems for TB that exist, we are suggesting this new conceptual framework for indicators. So we have different sets of indicators and disaggregations to be reported rapidly, so weekly or monthly, for example. So here we recommend only a single indicator, the case notifications, for example. And then depending on what the objectives of the data use is, we have different timeliness of reporting of indicators. So a single indicator for rapid reporting, a few more, around 10 of indicators for quarterly reporting, and then a larger number of indicators for annual reporting in order to be able and address all objectives for the collection and use of data. So we have also defined the absolute core set of indicators to report and use that are recommended for all countries, irrespective of what type of surveillance system they have. But again, keeping in mind how difficult it is to consolidate some of the data for countries, for example, that have paper-based systems, we have really tried to keep this core set of indicators to an absolute minimum. And then we also have sort of another subset of additional disaggregations and additional indicators that are recommended only if digital case-based surveillance is being used in the country. And then we also have some additional indicators that countries can consider using for their own purposes that are not necessarily relevant for all countries. And then we finally present recommended use and visualizations of these core indicators. You can find all that in chapter 4. Next slide, please. So now I would like to talk about what we refer to as good practices for strengthening TB surveillance. Next slide, please. I will start first with the schema, what you see on the left side of how we imagine the TB surveillance in a country. So we want a surveillance system that allows us to capture information all along the pathway of prevention and care for TB. So we want to be able to monitor and collect data on screening, on diagnosis, on treatment, and the management of comorbidities. We also recognize the fact that data are generated in different locations. So most often we have data generated at the health facility level, but of course, there are data on the same individuals that are also generated at the lab for bacteriological confirmation, for example. And more often, these days, as part of mass screening campaigns, we also now have data that are generated at the household level, at the community level, or at the workplace. And of course, you want to be able to connect the data that are collected on these individuals into a single consolidated surveillance database. And what you need to be able and remember and really this is much more relevant these days, is to really ensure that whatever it is that the TB surveillance system is doing, it is doing it in parallel with or as part of the overall public health architecture. So we need to keep in mind that we need to make this as easy as possible, and we need to avoid duplication of effort as much as possible. So we're recommending that TB surveillance systems operate under this collect data once and use multiple times approach. So data should really be collected at the health facility once for different reasons. So, for example, for offering health service delivery, or for program manager, and for global monitoring. So we really need to stop the duplication of effort of collecting data, for example, on a paper system, and then also on the same data on a digital system, or also to collect data on separate forms for TB and then others for the health facility level. We really need to move away from that as much as possible, and really make sure that the data are collected once and are used by multiple users and address multiple objectives. We also recommend the unification of all systems into a single system for all types of TB, for drug-resistant and drug-susceptible TB, and all locations. So we really should have a single digital system that allows us to collect information from different locations and for all types of TB. And so that means that we need to be able to link data on the same individual that are collected all along the pathway of prevention and care. And then finally, just to say that in order for us to be able and accomplish that and achieve that, national TB programs and the surveillance teams of national TB programs need to establish and maintain strong links with relevant national stakeholders that work on digital health, that work, for example, on the national CDCs, anyone that is part of this public health architecture. So we really need to promote this is part rather of this integration of TB surveillance into the overall public health architecture. Next slide, please. So another area of strengthening the surveillance system is, of course, the quality of the data. So we now define data quality across 6 dimensions: so accuracy, completeness, consistency, timeliness, validity, and uniqueness. We also offer a very clear description of data governance and design features. So any surveillance system for TB needs to clearly define what are the roles and responsibilities for data governance. Then we need to establish data sharing frameworks and agreements with other government entities or the private sector. We need to ensure confidentiality and safety of data. We need to make sure that we provide feedback for all users, so not just ask people at the health facility level to collect data and send it upwards to the national level, but also provide them some feedback, engage with them a lot more. We need to make sure that we use specialized software for surveillance purposes. So not Excel, but something that really addresses the issues that I've already described in terms of what the surveillance system for TB should look like. We really need to promote this use of a unique ID to facilitate data linkages, and we need to make sure that there are financial and human resources available to sustain our surveillance system. And then finally, we need to be to ensure the data validation and assessment of quality of the surveillance system, and we can do that either through routine data validation checks at the health facility level, as well as all the higher administrative levels. And then we can also do that as part of implementing periodic evaluations of data quality. Next slide, please. So this is a really important one. the strengthening the system coverage. So we know that in TB, we base a lot on case notifications, and we know that in most countries, in every country rather in the world, we use case notifications for as a proxy for TB incidents, but there is a gap between notifications and incidents, and the gap is largely, sort of broadly speaking, is due to two things: underreporting, so people who are diagnosed and treated for TB in part of the health sector that is not linked with the national TB programs, and then underdiagnosis, so people who are either do not reach health services, or they reach health services, but for whatever reason they're not diagnosed and put on treatment. So we now have new material that we recommend to use in order to understand and address both of these issues, underreporting and underdiagnosis. So for underreporting, there is new material that talks about how the integration and interoperability solutions with other databases that hold information on people with TB disease can be established. We talk about how you can carry out these data linkages across these different databases. And when I talk about different databases, we're giving here some examples. So it could be a database of the laboratory network, or the private sector, or using health insurance records. So depending in the country context, of course, there are usually different types of digital databases that exist out there that the official TB surveillance system should be trying to carrying out these data linkage exercises with. And in fact, even if these digital databases do not exist in the country, then there is a way going about this by implementing an inventory study, for example, which allows you to carry out prospective data collection with field operations and really establish these digital databases and link them with the official TB surveillance system. And then in terms of understanding and addressing underdiagnosis, really this is about ensuring that provider-initiated TB services take place at the health facility level, at the household level, and community level. Through those activities, we can identify people with presumptive TB, screen them, and confirm bacteriologically whether they are a TB case and start them on treatment. And how is, and of course, in the context of surveillance, we need to make sure that we have a surveillance system that allows us to make these linkages clearly and with a good quality. Next slide, please. So the last main theme that I will cover is the one on digital surveillance and associated products. Next slide, please. So when you are establishing a digital surveillance system, you need to be thinking in terms of the different data flows that an individual that accesses the health system follows. So I'm showing you here an example, data flow for an individual with presumptive TB. So in this case, we identify and enroll people with presumptive TB. We then diagnose, we then take specimens, we implement some lab tests on those specimens, and we have results. Based on those results, we identify whether someone has TB or not. If they have TB, we notify them and give them a registration number. Then we put them on treatment. We monitor the laboratory tests and results throughout the treatment, and then we have a treatment outcome. And once that happens, the record is closed. This is just an example. I'm not going to go through that in detail, but whenever a digital surveillance system is being developed, we need to be defining these data flows, all possible data flows that we want to be able to capture with that digital system. Next slide, please. So as part of the guidance, we now have some content on how we can establish or strengthen a case-based digital surveillance system, and how to ensure that is a single, as I've already talked about, system that captures information for all TB cases, all along the locations where data on the same individuals are being collected, with strong linkages to other components of public health surveillance. So in Chapter 6, we provide a clear description of the advantages of case-based digital surveillance systems and how they should be used in practice. We provide 8 case studies of national experience in establishing and enhancing case-based digital surveillance. And then in Web Annex F, we also provide evaluation results from the implementation of the DHIS2 tracker in 5 pilot countries. Next slide, please. And when thinking about digital surveillance and implementing digital surveillance, we really would like you to consider these 3 main pillars, and under each pillar, the key components, in order to not just develop and establish a system, but make sure that that is done successfully and sustainably. So the 3 pillars that we are suggesting you consider are governance, system, and financing. And under governance, we are recommending that you consider the components of establishing clear scope, purpose, and objectives, establishing roles and responsibilities of all stakeholders, establishing decision-making committees and networks, and making sure that supportive legal frameworks are available. And equally, we provide information on key components under the system and financing. Next slide, please. So in addition to the general guidance about how to go about establishing successfully and sustainably a digital system, we also provide very specific associated products that can help countries to transition from paper to case-based digital surveillance. And we do this in 2 ways. We do this providing these software-specific DHIS2 TB digital packages that we have developed in collaboration with the University of Oslo. So we have basically developed the standards for data recording, reporting, analysis, visualization, and use. And based on those standards, we have translated these standards into digital packages for aggregated level data and case-based individual level data. And we have developed these packages basically according to the recommendations that I have already presented. So for example, the TB tracker, the DHIS2 digital package for case-based data has been developed in such a way that can capture information on the same individual at the health facility level, at the laboratory, at the household, community, and workplace. And then we have also developed a lot of country support materials. So there's an installation guide, there's an exercise book, there's a number of presentations, and there's an e-learning course on how to use the core indicators that are collected as part of TB surveillance. And you can follow these QR codes that I have on this slide to see a lot more detail on what I have just talked about. Next slide, please. So in addition to the software-specific associated products that we have developed, there might be countries that do not want to use the DHIS2, of course. So we have done quite a bit of work into developing software-agnostic material that can support countries develop or strengthen a digital surveillance system for TB using the SMART guidelines. So the SMART guidelines are a WHO-wide, it's a new approach to presenting WHO content as digital components in order to accelerate uptake by countries. It is a 5-step pathway, the SMART guidelines, starting from the narrative step all the way to software development and AI use. In TB, we have developed and have published the TB DAC, the Digital Accelerator Kit, which is the step 2 in the SMART guidelines. And essentially what we have done is we have developed this requirements document that is split into 8 different parts. And we have developed this document by building on existing TB narratives, so on existing clinical guidelines for TB, on in-TB guidelines, on the TB knowledge sharing platform, as well as on a number of specific digital tools that have been developed for TB. Next slide, please. And just to say that the SMART guidelines, in fact, can be used by any country. So in a context where a digital system does not yet exist, SMART guidelines can kickstart the requirements gathering process and essentially reduce time and resources. If a digital system is established, then you can still use SMART guidelines to update and align your national systems with existing WHO content, including the interoperability. And then finally, you can also use SMART guidelines in order to update existing paper register systems and decision support logic. So in fact, the SMART guidelines, and in this context, the TB DAC that we have developed can be used in every country. Next slide, please. So now I will be providing 4 country case studies of good practices for strengthening surveillance. So based on the theory that I have just presented, I wanted to show you some country examples to prove that it is possible to actually achieve these good practices and strengthen your surveillance system. So next slide, please. I will first talk about the Brazil example, where the use of a unique person identifier has been established and is used for surveillance purposes. So in Brazil, there were a lot of individual level data on mortality and morbidity. There still are, of course, and these are data of high quality, but they were not linked. They were collected into different databases, and really the databases were not speaking to each other. So there was a lot of work that was done at all levels, from the health facility level to the state level to the national level in Brazil, where the linking of these very large databases had to happen. And in fact, in Brazil, there is very important expertise, high quality expertise in carrying out these data linkage exercises, but they were very consuming exercises. So it used to take more than 30 days to actually carry out this exercise by a highly specialized team in the country, just for 1 year's worth of data. And then as part of the TB epidemiological review and surveillance assessment that we carried out in 2018, one of the recommendations from that assessment was to, in order to facilitate the linkages, to establish and use a unique identifier for each patient for surveillance purposes. So in fact, since then there were a lot of consultations at the technical level, at the political level. There was engagement from the NTP with parliamentarians, and after a few years, there was this presidential law that came out in 2023, which established the Cadastro de Pessoas Físicas, which is this registration number for citizen identification in public health databases. So the unique ID was established, and there was work that was done to modernize the code and linking methodology using Python, which essentially made it much faster to carry out these linkage exercises. So the exercise using this new approach went from 30 days to 3 days. So really significantly improved algorithm approach. And as a result, there is now a new national ID that has been introduced into the drug-resistant TB system, into the TB preventive treatment system, and into the tuberculosis system, the SINA and vital registration. So the SINA system is, in fact, in Brazil is an interesting example, because the SINA system is the system for all notifiable diseases, not just for TB, and the implementation of this unique ID into the system, because it is not under the purview of the NTP, it is taking longer, but it is in fact in process. So in terms of the lesson learned from this experience, we now have a situation where we have facilitated data linkages, we have a significantly decreased processing time, and we have improved the data quality. Next slide, please. The next example is that of Pakistan, and this really provides an example of all the work that has been done to transition from a paper-based system to an aggregate digital system, and then finally to a case-based digital system. In Pakistan, we have been collaborating with the National TB program for many years, and as you see, we have implemented in collaboration with the NTP and our partners epidemiological reviews in 2016, in 2019, and 2022. And of course, this transition from paper to case-based digital is not going to happen overnight, but I think the Pakistan example is a very interesting example because it is one where over a period of 8 to 10 years, there's been a lot of effort and a lot of work that has gone into transitioning from paper to digital case-based system. So on the right of the slide, you see all these, a summary rather of the actions that were taken. So mobilization of domestic and international funding through the government of Pakistan, Global Fund, the Gates Foundation, the selection of DHIS2 as the software of choice, the establishment of core DHIS2 teams at the national and provincial levels, a strong collaboration with University of Oslo, with University, both the headquarters in Oslo and the Pakistan office, as well as his Pakistan. The establishment and the engagement with key government departments that are working on digital health in Pakistan, the deployment of a national DHIS2 instance, the inclusion of all public and private facilities in the DHIS2 system, the development and implementation of a complete rollout of DHIS2, and then finally the implementation of the DHIS2 tracker, which started in October 2022. And at the moment, the tracker is completed in 3 provinces and 3 regions. Punjab is the last province in Pakistan where the rollout of DHIS2 tracker is planned for this year, and so is the integration with this tracker of the drug-resistant case surveillance system. And what you see in the results on the bottom left part of the slide is that 121 of the 157 districts are now using the system. More than 1,000 people have been trained on how to enter data and use data from the system, and more than 400,000 notifications have been entered into the system since October 2002. And what you also see from this graph is that that in Pakistan, and in fact that's true in every country, you don't just roll out the case-based digital system and then completely stop using the other system. So for the last couple of years or so, both the aggregate system and the tracker system were used in parallel. And what you see now is that in Q1 2025, we're now transitioning out from using the aggregate system and are really focusing on using the case-based system in Pakistan. So a lot of work, and of course this is not easy to do, but if it can be done in a country like Pakistan with a complicated administrative structure, then it can be done really in any country in the world. And just to say kudos to the team in Pakistan that has been working on this tirelessly over the last few years. Next slide, please. Now I will give you the example of Indonesia, and this is about understanding and addressing underreporting. Indonesia is another country where a lot of work has happened on epidemiological reviews and surveillance assessments. So there's been 4 since 2014. In 2017, 2019, and 2022. And really a common recommendation in all of these reviews was to strengthen the coverage of the TB surveillance by addressing the underreporting of people diagnosed and treated for TB but are not reported. And I'm just providing here a summary of the actions that were taken in the country over a period of 10 years. So a lot of work over a long period of time, but it reaped huge benefits. So the country established and enforced a mandatory TB notification policies. It simplified the collection of data at the primary healthcare level and the private sector. It developed a unified digital case-based surveillance system for drug-susceptible, drug-resistant TB. It implemented a series of data validation exercises in hospital information systems. It has been maintaining an up-to-date mapping of all public and private facilities and health providers that diagnose TB and linked those with the official surveillance system. It carried out 2 inventory studies, one in 2017 and one in 2023, and it established data linkages between the TB surveillance system and the Health Social Security Agency, as well as these large public and private hospital databases. And as a result of that, the TB case notifications increased from 323,000 in 2014 to 805,000 notifications in 2023. And of course, the blip that you see there, the drop that you see there in 2021 was due to COVID, but you also see that the country has fully recovered since COVID. And in fact, the huge benefit of that is that the underreporting of TB decreased from 41% in 2017 to 16% in 2023. So it is possible to carry out work to really address this important issue around underreporting. Next slide, please. And then my last example is the one of Nigeria. And this is another difficult situation where a country has really tried to understand and address underdiagnosis, to really improve the coverage of the surveillance system. So in Nigeria, once again, through an epidemiological review and surveillance assessment, there was a clear evidence of underdiagnosis. So in 2020, the EPI review, and a recommendation from the EPI review was to strengthen the coverage of the TB surveillance system by addressing underdiagnosis among people who seek healthcare or among those who do not access health services. So what the country did is implemented this series of actions. So number one, it introduced this active TB screening in the outpatient departments of the whole primary healthcare network. It expanded TB services with provision of additional gene expert machines to the primary healthcare network. It engaged with the private sector to increase referral from the private sector to the PHC network. And then it carried out a series of community outreach activities, again, to increase referrals to the PHC network. And as a direct result of that, there was this huge increase in treatment coverage from only 24% in 2018 to now 59% in 2022. So, and just to say that it has done that, also ensuring a high quality of services offered, as evidenced by 81% of all cases notified being bacteriologically confirmed, and the treatment success treatment success rate at over 90%, and HIV screening 97%. So once again, an example of how of a country where it very successfully addressed this really difficult issue of underdiagnosis. Okay, that's it for now. So I'm now going to ask Namdeep to provide a commentary before we open the floor for questions. Namdeep, over to you.
Thank you very much, Babis. Good morning, good afternoon to all who have joined this webinar organized by WHO and the Global Fund. I will like to really start by appreciating Babis, Marek, Gita, and colleagues in the WHO Global TB program for putting together this webinar and disseminating the new surveillance guidance. It is quite timely, and I think your presentation was quite insightful overall, Babis. As already mentioned, since the last surveillance guidance was released, a lot has changed in the TB landscape. And because of these changes, it is only important that we have a global surveillance guidance that kind of reflects the current realities. But above all, a surveillance guidance that also responds to the needs of the national TB programs. I know that There would be a future session that looks at the updated terms and definitions, but just to give a heads up that there are some changes in the terminologies for a few indicators. I think one thing Babis may not have mentioned yet is in a lot of cases, it doesn't really change the standard way of measuring them. It's just really the way that information is now referred to that changes to some extent. And but that doesn't mean that at the country level, there won't have to be some alignment that may need to take place, and this will have to take place. Just to give a heads up, for the Global Fund, modular framework indicators have been for the next grant cycle, which is GC8 that starts in 2027, have been revised with internally within the Secretariat, but we received input from our technical partners, WHO, Stop TB, Gates Foundation, others. And these revisions for some of the indicators, we ensure that they are already aligned with the new surveillance guidance. So use of the terminologies like new episodes of TB, relapse for recurrence instead of relapse, you will see this. So I think it's good for you to have this already on your radar as we progress towards the commencement of the next grant cycle. I want to reemphasize two things from this presentation. The first is, and I don't think we can say too much, the importance and the demand now for timely quality data to be used locally for decision making. That's the first. But more importantly is the transition from paper-based systems to digital surveillance systems, especially case-based systems. The benefits of case-based systems are undeniable. Babis has given very, very clear examples in some countries, Indonesia, Brazil, Nigeria, and Pakistan here. So, but it doesn't mean that countries are not doing more. There are other countries that are doing this. And it is important to remember that investments, actions that aim to strengthen digital surveillance systems at country level and its use remain a priority for the Global Fund, especially now, where we are seeing national programs facing some level of funding constraints and may require some additional prioritization. The truth is, even if we have funding constraints, the TB epidemic is still here with us, right? The TB bacteria is not going anywhere. It doesn't know what's happening financially. And so we will still, when I say we, the global TB community, country level, regional actors, we will continue to fight the epidemic. And this would require programmatic monitoring, be it at the subnational level, national, regional, and global level. And with that, of course, comes the use of the data, right, for better targeted interventions, country planning, and so on. So I want us to remember that as we prioritize and face and focus on this very important, incredibly important task of diagnosing people and treating them, there has to also be a complementary action on also prioritizing the strengthening of surveillance systems at country level for and better data use at that level too. I would also add that despite the progress that countries have made in this space, we still have some gaps, right? And with these gaps, it's also important even for those that have actually started or have been working over the years in strengthening our surveillance system, it is imperative that we continue to ensure and that we set up and have this unified, interoperable surveillance system at country level. Babis has mentioned it has to be contextualized within the public health architecture, and this is imperative because as the resources are going down, you need to bring everything closer together. So integration, interoperability is very key. The days where we have parallel DRTB systems and DSTB systems in the same country, or where we have private sector community data systems with TB data that the National TB Program doesn't have access to, or they have limited access to. Those days have to be behind us, especially as programs continue to strive for program efficiency. And I think one other thing I would say is with the dwindling resources, where countries prioritize robust functional case-based surveillance systems, it reduces the reliance of the countries on some of these non-routine, periodic data collection activities. And sometimes this could be expensive and time-consuming for the national program. So that's really the bedrock, right? That routine surveillance system being strengthened. I will stop at this point. I would like to really thank everyone who has joined, and I encourage you to familiarize yourself with the contents of the new surveillance guidance. It's quite rich. What Babis has done is just a synopsis, but there are a lot of in-depth information in that document that will be beneficial to national programs. Thank you.
Great, many thanks, Nnamdi, for this commentary, and perhaps just to also add that I do recognize that there is a lot of new content and new material, and in fact, most of it is related to activities that perhaps we're not very used to implementing, but the content has been developed based on really what we have seen from the field, as I said, in more than 100 countries since 2013. So we really are trying to make sure that all the lessons that we have learned on what NTPs and their partners and stakeholders can do to strengthen their surveillance system, in fact, will benefit all countries around the world. Perhaps not everything is relevant for your country, but I promise you that a lot of the material that is being covered and a lot of the activities that are being suggested and recommended will be relevant for you, and they will make your system stronger and more reliable and more sustainable. So I would really encourage us all to try and, even if it is a little bit outside our comfort zone, to really try to address that and really look at the content. I'm looking around the table to see if perhaps anyone else has any comments that they would like to make before we open the floor for questions. Okay, no, let's open the floor for questions now. Okay, so I think we have a bit of time. If people would like to ask a question live, I know that Marek and Gita have been busy trying to respond to your questions in the Q&A part of the Zoom. Okay, so why don't we take some questions? I see. Ivan Bruno, please, the floor is yours.
Trial.
We cannot hear you, Ivan.
Trial.
Hold on a minute.
Trial.
Hello?
Trial.
You can hear me now?
It's not working. Oh, now we can hear you. Yes.
Okay, so yeah, hello everyone. So my name is Ivan Rono, National TB Program in Kenya. My question is a simple one, really. That is touching on the issues to do with the epidemiological reviews that could be coming up probably next year. So in relation to the new terms, new definitions, the new revisions, when is it expected? I know it could be already in the checklist. When is it expected to be used to? Because I know normally there's a question on whether the country has adopted the new definitions, and also the issues to do with the WHO report that is there. I hope I was clear.
Yes, thank you for that. Okay, let's take a few more questions and we'll get to your question. So Dr. Laik, please go ahead.
Thank you, Babis, for a very nice presentation and for this webinar, which is really has come at a very critical point when the countries are planning for their epidemiology reviews, including Pakistan in the program review. Very helpful. Thank you for that. I have just small queries. First of all, the country examples, very motivating. And I was looking into the Nigeria's success on improving the bacteriological confirmation, where all the countries have the same tools, updated tools. This a very good jump from 51 to 81% of bacteriological confirmation. So I'll be requesting colleagues from Nigeria for a very brief comment on that. Secondly, to Nandi, thank you very much for very comprehensive comments. On the efforts which we have been done together, Global Fund, WHO, and all the partners, we have the gains. But the current fiscal scenario, how we are going to mitigate it so that the efforts are sustained. Thank you very much.
All right, thank you, Dr. Lake. Who is next? Let's take one more question and then we can. Is there anyone else? Obioma? Okay. Obioma, the floor is yours. Please go ahead. And sorry, I should have said introduce yourselves briefly. So please go ahead. Obioma, the floor is yours.
Okay, thank you so much, Babis. Thank you, other speakers. An amazing session we had this morning. Particularly, really excited on the SMART guidelines and trying to also read up and see in what area, what we need to do, where we are, really like assessing where we are in terms of this and what we might need to put together as a country to follow or fall in line in terms of it for whichever place or aspect we may have gaps as of now. I just want to also believe that this is more like orientation. There'll be other hand-holding or further discussion on a country level where maybe country focal persons would have to look into this with us and we know what we can do better. Just more like it doesn't stop at this orientation. That's talking from a Nigerian perspective, especially at this point in time where we are in, we're in a very important place where some things we can take advantage of. The EPI review, interim review, NSP development, these are key times for us, and we will need to ensure that key things that we need to do and have reviewed or even affixed into the document is done. Then I think I'll just quickly respond to, there's a question for Nigeria. And I just want to say that typically for Nigeria, I think I would just summarize it by saying like here to do, ensuring that not just to have recommendations on your paper or suggestions from the different reviews or technical assistance, but to breach the that no-do gap is actually key, so that you step out of just having those documents and seeing the recommendations from the review, the EPI review, just like Babi said, and knowing that we need to implement. So all we needed to do was to look out for what are the gaps and how do we need to ensure that we put this into practice. So basically, each and every step of ensuring that we either close the gap in terms of those identified and placed on treatment, so that we don't have, even though we've not done an inventory study because of resources, but seeing how much more to do a mop-up was important, ensuring that everywhere patients go, that we ensure that we have a way of screening. So we discovered that within the facilities, those high burden PHC facilities that Babi's mentioned, that we had like more than 10% of patients who visit the facilities, but not even to the dot site, who would have been missed. And that in numbers were giving us like 20-something thousand patients who would have missed. And adding 20-something thousand patients to what we have identified in a year is a whole lot of sum. So including screening, going further into the communities and all those aspects. So I'll just say every country is different, but at those reviews and the recommendations that come from the review, it's now as a country to know how exactly to take it up and ensuring that it doesn't end on the papers, but that you take steps into implementing it. That was one of some of the things that happened to us. And like Babi say, in rounding off, we at that 2022 we're about 54%. I think, in treatment coverage. But as of 2024, we have gotten to about 79% in treatment coverage, and that's just by keeping up with exactly what we have learned and ensuring that we push further what we do. Thank you very much.
Excellent. Many thanks, Obioma. Okay, so why don't we give some answers to these comments and questions, and then we'll see if there's more questions coming up. So I just wanted to start by providing a general comment around EPI reviews and, in fact, also program reviews. We all know that we are in a situation where funding is limited. So unfortunately, we're not in a position to basically carry out and implement all these activities exactly as we used to do in the past. But we are trying to find alternatives that can still support you in really understanding what the analyzing the data, using the data, and making sure that the data inform the development of your national strategic plans and the development of concept notes for funding requests, etc. So we are still trying. So the team here that is responsible for the coordination of the EPI reviews, we are still trying to, for example, establish some hybrid approaches. In fact, we do have a review coming up in Indonesia. We also later this month, and then there is another one planned in Pakistan in July, and then another one later on in the year in Nigeria, where we're trying to implement them in a hybrid approach, where perhaps we can, if the countries are comfortable with sharing the data beforehand, we can carry out some of the analysis beforehand. Oh yes, and I forgot also Tanzania. We're also supporting Tanzania virtually, completely virtually at the moment. So there is something that we can still do. So the team, as long as the team is here, we're here to support you. So you know, this is an area of work that we feel is extremely important, and we want to continue doing it. If there are countries that are interested in some of the support, please reach out. I cannot promise that we will do. We can support everyone, but we can definitely try to find ways, even if it doesn't involve you know, one of us traveling to the country. We can definitely find ways where we can try to perhaps facilitate the analysis, or to link you up with some of the consultants that we have trained over the years. In fact, I should also say that we do have a roster of very capable consultants, if there is funding at the country level, that we can link you up with, and we can do the work. So please have contact us. We will try our best to support you. So that's just a general comment around the epidemiological reviews, and I don't know if So and of course the program reviews and anything that feeds into the NSP development and the concept note development. On the specific questions, so Ivan, I think you made a comment about when we expect, when countries are expected to adjust the data collection forms and the digital systems according to the new definitions and the indicators. So as far as the global TB data collection is concerned, we're not using the new indicators and terminology this year. We will start collecting data next year. So from the 2026 global data collection is when we will fully implement this new conceptual framework of indicators that I have presented. So there is still a bit of time. And of course, we recognize that's why we don't do it very often, but we do recognize how much time and effort it takes to make changes at the way data are collected at the health facility level and reported all the way to the national level. So as far as the global data collection goes, we will start asking for this data in 2026. Countries that, of course, have not implemented it in 2026 can still submit data as they used to until then, right? So it doesn't mean that, of course, we're not going to be collecting the data. So we do recognize that takes time, and we want to do everything we can to support countries in transitioning, and we want to make sure that we get data from every member state and every country in the world. I think perhaps I'll see if Namdi has any response to Dr. Laik about the mitigation issues. And then just to say to Obioma on the SMART guidelines, we are also very excited about this work, and we can definitely look at this. Is in fact, we do this in collaboration with our digital and health innovations department. They are, of course, the ones that are leading the work on the SMART guidelines. We have just been developing the TB component of that, and we have a very close collaboration with that department. So I'm sure if there is interest in the SMART guidelines and perhaps implementing some of that at the country level for TB or other diseases, please reach out to us. We can definitely have a follow-up discussion on that.
Maybe I quickly comment on that.
Yeah.
Yeah, I think that was a very good question from Dr. Leek. I would say that I think the simple answer is searching for more efficient ways of doing things at country level. And this cuts across, it's not about only the surveillance component, but just everything related to TB programming, all the components. We've seen in the past where countries had resources and could depend on predictable amounts from a lot of donors over time. And with this, they planned, it fed into national strategic plans to address the gaps that existed. Now, as we start to see this reduced fiscal space for TB programming, it is important that at the country level, the national program and partners look line by line at each activity and see, are there things that are most important at that level? Are there things that could be done a bit better? Are there ways we could integrate certain processes at country level that will enable the limited resources to be able to take care of all these needs? And with this, just in the past, I'll give you an example. We've had scenarios where because some countries received a lot of resources from donors and from their domestic funding, when they were planning a surveillance system, they could think really large scale and really bespoke models and things like that. If the resources are not as high as they used to be, maybe you'd start thinking about cheaper alternatives that are able to still address the digital needs. If you need the system to have offline capabilities and things like that, and have relatively good case-based systems that also require not a lot of effort to maintain. We've had examples where people had to fly in from different parts of the world to some countries just to address issues in their digital systems. And in this kind of scenario, we need to start putting on that thinking hat to identify where are the places we could actually cut costs, where are the places we can do things better. But one thing we are saying is surveillance still remains the bedrock for you to understand the trend in your epidemic, for you to understand your performance against programmatic targets, and to also just generally strengthen your routine system overall in the country. Thank you.
Great, many thanks for that comment, Namdi. This is extremely relevant, and in fact, I think it addressed a couple of the questions that have been published on the Q&A. All right, so I think in the interest of time, I think we should move on to the last part of this webinar, but I will say that if there are any questions, we will go through the Q&A at the end of this webinar. If there are any questions that remain unanswered, we will be answering them and publishing them on the FAQs, on the FAQ link on our website. So let's move on. Could I have the slide again, please? Right, thank you. So in summary, so there is a new guidance on TB surveillance. There are new associated products with some updates to terms and definitions. And I've given you a very brief overview of those. Please feel free to contact us with any specific questions afterwards. We do recognize there is a lot of material, but I do promise you it is material that will benefit you and your systems as you are moving forward to strengthen your surveillance system and ultimately improve the work of the NTPs. We also have a new conceptual framework for reporting indicator based on timeliness of data and based on the digital status of the TB surveillance system in the country. We have developed and are providing a lot of new content to support you in the transition from paper to case-based digital surveillance. And we have done that by providing both software-specific and software-agnostic content. There is much bigger focus on good practices to strengthen the TB surveillance system, so improve the coverage and improve the quality of the system. So we're not just focusing on indicators to collect and report. There is really a lot of new content that will help you improve and strengthen your surveillance systems overall. And there are a lot of lessons learned from epidemiological reviews and surveillance assessments that we are now sharing with you that we believe can benefit all countries. And then finally, I will go back to this really important point that it is absolutely imperative for TB programs to ensure either integration or interoperability of TB surveillance within the overall public health architecture. And I don't want people to be afraid of integration. In fact, we need to be part of it. We need to embrace it and be part of it. Integration doesn't mean that the TB surveillance system or the teams will cease to exist. It means that integration in this context means that there is still a need for disease-specific teams that will collect the TB-specific information and use it to guide the country towards ending a specific disease, in our case TB. But integration and interoperability is another way that will allow us to establish a stronger system and a more sustainable system. So really, I would encourage you, and in fact, we have seen this in most countries already, but even if you're not doing it, really, please reach out, make sure that you engage with the other stakeholders, relevant stakeholders in the country. Most country in the world is now, for example, thinking about digital health transitioning. So make sure that you're part of that conversation. Make sure that TB is there, it's visible, and it's providing solutions moving forward. So don't be afraid of that. Really, in fact, exactly because TB has done so much work and NTPs have done so much work on establishing surveillance systems, they can be a building block to support digital health in the country. So don't be afraid of it. Embrace it. Use the lessons learned from the implementation of TB surveillance to really inform digital health transitioning in the country overall and the public health architecture overall. Next slide, please. So this is the last slide. So just to say, to repeat again that the new terms and definitions in WHO's 2026 round of global TB data collection, this is when we will start asking for these new terms and definitions, recognizing that many countries will take time to adapt. And again, just to reassure you, even if we do start asking for these new terms of definitions in 2026, if some countries have not yet transitioned even next year, we are still going to be collecting data from those countries using the previous set of definitions and terms. FAQs are published on our website, and this is a live document. Please be aware that it will be kept up to date based on questions received from you. So if you have any other questions, please send them to tbdata@who.int. Okay, and then lastly, we hope you have enjoyed this webinar. We are planning additional webinars to promote this work. So the first one has already been set. There will be a dedicated webinar on June 12th. We will be sending a save the date that will specifically look at, present rather, at the associated products that we have developed on data use to guide policy, planning, and programmatic action. Please join that. In fact, it will be quite an interesting webinar on really talking about the TB Digital Platform, the e-learning module, a lot of the DHIS2 dashboards that we have developed. We do think that you will enjoy that. Now we would like to hear from you. I'm listing here a few other potential subjects for future webinars. Gita, how are we going to run this poll? Can someone right? So we're now asking you to let us know. Yes, there we go. So please get the QR code and log into the Zoom poll. Can someone, you want to explain it?
Yes, thank you. So for the first questions for the upcoming webinar, you have seen already the questions on your screen. So you can put multiple questions on the themes or topics that you would like us to showcase in the next webinar. So we will allow a couple of minutes before we launch a second questions. Okay, we see there are around 56, 59, 60 people already answering. Keep your answer coming so that it will guide us on which webinar we should prioritize in the future. Okay, and so I think now we can go to the second questions. You want to share the result? Okay, so now the second question is fill in the blank. So basically, if there are other topics that are not showcased in the previous poll, in the first question, please type your suggested topic that you would like us also to cover in the next webinar. Thank you.
Recording method at the tone. When you are finished, hang up or press pound for more options.
All right, let's give people a few more seconds to see if there's additional suggestions. Okay, so I see the requests are coming in, so let's just give it one more minute and then we can close. That's a good one. Okay, Gita, can I have the last slide, please? So just to say thank you all for the participation. We do hope you have found this webinar useful. I thank a friend and colleague Namdi for being here, Gita and Marek for all the work they have been doing on this in this area. Please and Natasha for all her support in to setting up the webinar, and in fact many other people and all the NTPs with whom we have been collaborating for many years. We value these relationships hugely, and we want to be here for you and support you even through these challenging times. So if you have any comments or questions, please feel free to contact us. So until the next webinar in a few weeks' time, thank you very much and have a lovely day. Bye-bye.